before starting this webinar, please recite the Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم يا أيها الناس كلوا مما في الأرض حلالا طيبا ولا تتبعوا خطوات الشيطان إنه لكم عدو مبين إنما يأمركم بالسوء والفحشاء وأن تقولوا على الله ما لا تعلمون. तर्जुमा, लोगों, जो चीजें जमीन में हलाल तय्यब हैं वो खाओ और शैतान के कदमों पर ना चलो, वो तुम्हारा खुला दुश्मन है। वो तो तुमको बुराई और बेहयाई ही के काम करने को कहता है, और ये भी कि खुद के खुदा की निस्बत ऐसी बातें कहो जिनका तुम्हें कुछ भी इल्म नहीं। सदक़ल्लाहुल अज़ीम।
जज़ाकल्लाह। ये जैसे कि मैंने कहा 23rd PM में एकेडमिक वेबिनार है और इसमें हमारे आज के स्पीकर हैं प्रोफेसर रिटायर्ड ब्रिगेडियर आमिर इजाज साहब। ब्रिगेडियर आमिर इजाज साहब एक हमारे उस्तादों के उस्ताद हैं. He has written so many articles, so many books. Especially he has a well name in chemical pathology, and today we will discuss diagnostic accuracy study, how to go about it. We know the lab is very important, especially during the phase of the corona. The labs becomes more important. So, but there are so many problems how to make the quality control, internal quality control, external quality control, to increase the reliability, not only the patients and also to the clinicians. That is why we are continuously making these webinars in collaboration of clinician and pathologist. Dr. Amir Ejaz, now it is over to you.
Thank you very much, sir. And I am thankful to PMA, President Dr. Salma Kundi, Dr. Kazi, and Professor Mulazim, Professor Rashid for giving me this opportunity. And I hope you will learn something after the series, the excellent series of lectures conducted by Brigadier Nuzul Shahid. And she really dealt the topic very nicely, and I'm just a small, I will do just a small contribution and whatever she has built. The diagnostic accuracy study, she mentioned the concept of these studies and what are the importance of these studies in clinical practices. So my topic today is actually how to go about it. This is not limited for chemical pathologists. This is not limited even to pathology. Diagnosis is done, the teamwork, which comprises radiologist and clinician also. So you will find diagnostics accuracy studies being carried out by pathologists, by radiologists, and some of the clinicians also. So the specific learning outcome is what are the skills to carry out these diagnostic studies. And you must have heard these terms: specificity, sensitivity, positive predictive value, negative predictive value, likelihood ratios, ROC curve. These terms, how we determine these terms, what I'm sure whenever you read some articles on any clinical topic, whenever they mention some laboratory tests, some radiological imaging, they do mention these parameters. So who determine these parameters and how these parameters are determined? What are the studies carried out for these. These are called diagnostic accuracy studies. So if you don't mind, I will do some interaction also. And by no means I want to test anybody. This is just to keep you involved, and the interaction actually increases the involvement of participants. So if you have got a copy pencil, you can write on the answers. So, and then you can share it in the chat box if you want. If nobody wants, I will give the answer myself, but that will you will really enjoy if you do the interactive things. So my first task is uh, there's a trainee in histopathology has planned a study to compare the results of a special staining for an oral cavity cancer with a presently used fish assay considered to be gold standard. Name the study type she is using. Which type of study is she doing? Uh, uh, she's comparing the special staining for oral cavity cancer with a very sophisticated technique which is called fish, keeping that in as a gold standard. This study is a diagnostic accuracy study. So diagnostic accuracy studies, as I told you, mostly these are done by the people who are involved in diagnosis, either lab diagnosis or radiology or some other fields which are related to the diagnosis. In studies of diagnostic accuracy results from an index test is the new test or the test which is under evaluation, are compared with the results obtained from a gold standard. Now, the latest term for gold standard is reference standard on the same subjects. Such accuracy studies are a vital step in the evaluation of a new test. Now, when they are studies, when the test has been just introduced, or before actually starting practice this test in clinics, we carry out. We do not do it ongoing. This is done once the test has started. And for example, if the test is done for disease A, and now you want to do use the same test for disease B, you have to carry out these studies once again. So it has to be a disease specific, may be used for new employment of an existing diagnostic technology. There are four essential parts of diagnostic accuracy studies. These are called PERT. PERT is the acronym used for it. Number one, of course, the patients. Selecting a group of patients, for example, suspected cases. Then index test, the test in question, for example, a lab test imaging technique. A reference standard, what is the best reference gold standard to diagnose the target condition? For example, histopathology. In pathology, in laboratories, usually the histopathology is the gold standard because this is the final test and their diagnosis is taken as final. Target condition, which condition is to be ruled out, ruled in or ruled out. So these are the four pillars of diagnostic accuracy studies: patients, index test, reference standard or gold standard, and target condition. So without four of these, you cannot carry out diagnostic accuracy studies. The reference standard or the gold standard can be a single test or a combination of methods and techniques, including clinical follow-up of tested subjects. So usually it is a single test. Usually, I told you, usually it is a histopathology or biopsy test, but it can be a combination of laboratory tests or a combination of laboratory tests and clinical follow-ups of the tested subjects. So anything can be used. But very importantly, the reference standard or gold standard has to be selected very carefully. Once selected, you cannot change it. And there is another criteria that this should be itself about 95% specific and sensitive. Less than 95% specific and sensitive, you cannot use. Generally, it is not recommended that this test should not be used. But sometimes you have to compromise some of these criteria. what about this gold standard? Now, uh, just to give you some concept about the gold standard, I am quoting this example. This is an actual example of a research study. The diagnostic accuracy of anti-cyclic citrullinated peptide antibodies, CCTP, in rheumatoid arthritis. Rheumatoid factor as a gold standard. Now, the researcher is assessing anti-CCP, and they have taken rheumatoid factor as gold standard. Can you see any problem in this? If you if you want to give your comments, your interaction about this study, for example, this study comes to you for this paper comes to you for review, what will be your comments? What is the main? There are some basic issues in it. So can you tell me what are those issues? You can write your answer on the chat if you want. I will wait for 30 seconds for your answers. So I repeat, the researchers want to evaluate anti-CCP, which is a very sophisticated, very supposed to be a very good test for rheumatoid arthritis, keeping rheumatoid factor as gold standard, because RA factor is a very commonly done carried out test. So what is the main problem in this? I can see one answer in the chat box. RA factor is positive in other condition also. This is not specific. Good. Dr. Faiza Mushtaq, this is a good answer. The sensitivity or the specificity of RA factor itself is questionable. This is a good answer. Anything else? Anything else you want to say? Okay, gold standard has to be a very high sensitivity, 95% specific and sensitive. And whereas rheumatoid factor, as Dr. Faiza Mushtaq has just told us, is not enough sensitivity and specificity. There is another very important question. And this question is, if rheumatoid, for example, we say rheumatoid, excuse me, rheumatoid RA factor is a good test. It has got a perfect specificity and sensitivity, and it is available. It is its cost is low. So what is the fun of doing another test when you already have a a good test with a high specificity sensitivity? And why then you want to introduce another test? If such an accurate test is already available, then what is the requirement of another test? So then comes the question that why we introduce new test when the gold standard exists. The answer is that the gold standard is maybe very expensive, maybe it requires high invasive procedure, it requires a very high expertise for interpretation. This problem with the histopathology tests, biopsies. Although as I told you, histopathology tests or HRD and all those special stains, they are the final tests, they are the gold standard. But can you use these tests for monitoring? Can you repeat these tests? Can you use it frequently? Can you do the invasive procedure in every patient? So if gold standard does exist, but there are problems with it. For example, it is very expensive. It requires high standard expertise for interpretation, or it is invasive. Then you work on some other tests and compare it with the gold standard. So usually gold standard is expensive, requires more expertise or invasive. In this particular example, if RA factor is very good, you can use it as gold standard. So, but RA factor can be done on the blood. A simple test, no invasive procedure is required. Then why you have another test like anticyclic CCTP? So gold standard has to be very appropriate, and you cannot use tests like RA factor as gold standard. Ideally, if you want to evaluate, if you want to carry out anti-CCP evaluation, the diagnostic accuracy of anti-CCP, you have to use a test which is very superior to it. And if it doesn't exist, then you can use the clinical features You can borrow those the gold standard from a system field like radiology. You can use some imaging technique for this, but you cannot use RF test like RFFs. So how to go about it? First of all, very important, you have to select series of patients. Now, what type of patient? This is very, very important. Please be careful. Please, as they say, lend me your ears. आप जरा पूरी तवज्जो से मेरी बात सुने कि यहाँ पे जो हम पेशेंट सेलेक्ट करेंगे, the patient we are going to select for these studies has to be similar patients. For example, you want to do a test for pancreatitis. You have all your patient should be of abdominal pain. I'm just giving an example. The test will decide whether the pancreatitis exists or not. You cannot use the normal controls like we use in other research studies. We sometimes we select medical students as controls. We use hospital employees as controls. No, you cannot use those uh, mm, people as control. The controls and the patients have to be from the same population. Then the index test, which the test you want to evaluate uh, for diagnostic accuracy, and the reference standard, gold standard. I already told you some of the characteristics of gold standard. Compare the result of the index test with the reference standard. The final thing is how to compare it. Now I give you an example. Uh, if some pathologists are attending this talk and some radiologists, I give you a very important tip that uh, do carry out diagnostic accuracy studies, because these studies are published very quickly. For their publishing time is quite reduced. I collected data in another talk and presented it, that the studies which involved diagnostic accuracy, they were reviewed very quickly, accepted, because they are of high utility clinically. These studies are quite helpful for the clinicians. They can now know about the laboratory tests, about the radiology tests, and they can use it with more confidence. So I'm giving you an example of the diagnostic accuracy studies which have been lately published, carried out uh, by me and other authors. For example, this diagnostic accuracy of serum iron and TIBC in iron deficiency state. This was published in JCPS. You know, it's a impact factor journal, and in 2016 it published. Then accuracy of non-fasting lipid profile for the assessment of lipoprotein coronary risk factors. This was again published in JCPSP, and not long time ago, in 2016 it was published. Then diagnostic accuracy of uh, again, it's a diagnostic accuracy study published in 2016 in Pakistan Journal of Pathology. Then another diagnostic accuracy study, evaluation of random glucose, published in JCPSP not long ago, but in 2017. A novel clinical biochemical marker, which was published in JCPSP in 2018. So these are the examples that diagnostic accuracy studies are very good publications you can carry out. These are the fields open for pathologists, radiologists, and they can do these studies. And uh, what when trainees come to me with suggestions, they usually they design association studies. Those association studies or correlation studies, they are not of high quality, and the journals like JCPSP or JPMS, they do not accept those studies. So whereas diagnostic accuracy studies are given priority for publication. So there are other studies also uh, for uh, for uh, for diagnostic people. For example, outcome studies, reference values. We can have a separate talk on reference values, and then two statistical procedures. Uh, These studies are very good for clinical utility, and they are published quite often. In studies of diagnostic accuracy, we have already discussed this. What is the test in diagnostic study? Laboratory test, radiology test, imaging, history, clinical examination, function test, for example, lung function test, etc. So it is not only laboratory, it is radiology, history, clinical examination, function test, for example, lung function test. Now I give you another task. You have to help this training. And as previously, you can write your answer in the chat box. A trainee has been assigned to work on CA 19.9. This is a marker for CA pancreas, and which is being done in her lab for the last 2 years. She has collected data of 342 patients who underwent this test. 88 were with raised level, while rest were abnormal. The rest were normal. 88 were raised and rest were normal. She showed this data to her supervisor that he did not like it, and said that she should calculate specificity and sensitivity. So the problem is, can she determine specificity and sensitivity in this project? If yes, how? So this is the problem, that CA 19.9 is to be evaluated for diagnostic accuracy, and the trainee has already collected data of 342 patients. 88 of them were positive, raised levels. So how can she determine specificity and sensitivity in this particular study? If can she determine it or not? If yes, how? 30 seconds for your answer, but the first answer has already come. Let's see. Dr. Samairam, false negative should be added. Okay, how can we add false negative? No, cannot be done without gold standard. Dr. Aisha Siddiqa from PIMS, yes, you are very right. This study cannot be done because there is no gold standard. So how can you carry out a study just on the data of the just on the basis of the data of the one index test? So this will simply a association study or frequency study that we carried out 342 patients and 88 were positive, and it will be having a very low grade evidence. So if she can add some gold standard like a imaging technique or like clinical assessment or post-op assessment, etc., then only it can be a diagnostic accuracy study. So reference standard can be single test or combination of methods, techniques, including clinical follow-up of tested subjects. Please give examples of the test which can be employed as a reference standard. I have already given you examples, and they can be, mostly they are histopathology, but can be imaging, can be clinical follow-up. The term accuracy refers to the amount of agreement between the, now what we are looking for, we are looking for the agreement between the index test and the reference standard or gold standard. How much there is agreement? Now, once you have selected the gold standard, you have collected the data, and the reference standard you have selected. So how to go about it? Now, this is the very important chart, and this is the very important grid that you have already carried out both the test, index test and gold standard test, and how to make the grid. If the test is positive by the reference standard and positive by the index test, then it will be true positive. I repeat, if the test is positive with gold standard and index test, it is true positive. If the test is negative for the reference standard, but positive for the index test, it will be false positive. So very important lesson here is we cannot doubt reference standard. Once we have started this study, what is the result of reference standard is final. If reference standard says negative, it is negative. And if index says positive, the index says telling a lie. So reference standard cannot be challenged at any stage of the study. You should select it very carefully, but during the study, whatever reference gold standard says, it is final. Uh, uh, just in a lighter tone, as in house, who is the reference standard, who is the gold standard, and our staying is final, and you should not challenge whatever she says. I mean, the wife says, and that is the final, that is the gold standard. I hope all husbands will not forget it. Then index test is negative, and the reference standard is negative, then it is false negative. And if reference standard is negative, index test is negative, then it is true negative. So once you have collected the data, you can make this simple chart. It's very simple, very easy to make. Just sort it out, the true positive, true negatives, false positive, false positive. This is the all stat you have to do. Then just a few formula and you can build your statistics. But before doing this, please see what is wrong here. A trainee in chemical pathology has developed a technique of measuring calcium on atomic absorption with the colorimetric calcium assay taken as gold standard. If some chemical pathologist sitting here, can you please write your answer in the chat box? What is wrong with this particular study? That calcium by atomic absorption has to be assessed keeping colorimetric calcium as the gold standard. Can anybody write? What is the problem here? Dr. Faiza, colorimetry is not gold standard. Yes. Dr. Aisha, yes, atomic absorption should be gold standard. It has to be other way around. If you want to do it, there is another yes. You are very right. Both of these doctors, they are very right. It has to be other way around. If colorimetric is to be assessed, atomic absorption should be gold standard, because we all know that atomic absorption is a very high sensitive specific test for calcium, and it can be used at gold standard, not the colorimetric test. A field method cannot be a gold standard of a reference method. Two major flaws. Now, in this particular study, which I'm going to tell you, there are two flaws, and you have to find out those flaws. A trainee in chemical pathology is evaluating a new tumor marker for the diagnosis of ovarian cancer. She has selected stage 3 cases of ovarian cancer as subjects and female medical students as controls. Name two major flaws in our studies. I've already mentioned one of the flaws, but you can also find out another flaw. There are two flaws in this study design. What she's doing is, she is working a tumor marker for ovarian cancer. So selection flaw, yes, Dr. Taiba, you are very right. There is a bias, selection bias. She has only selected stage 3 cases. It has to be a mixture of stage 1, 2, 3, 4, and those subjects which have not been yet diagnosed. So there is a spectrum bias and there is a selection bias. What is spectrum bias? That medical students have been used as controls. You cannot use medical students as controls. So all these bias has to be removed before carrying out these studies. Series of patient control and patient from should be from same population. Yes, Dr. Ina, very right. It has to be same. It is not like case control study. It is, these diagnostic accuracy studies, these are not case control exactly. You have to take the same clinical condition, the patient of the same clinical condition. Only then you can evaluate, you can get the diagnostic accuracy of the particular test. What is the ideal reference? This is the question now. What is the ideal reference standard for a study on PSA? I'll wait for few seconds. Somebody wants to do PSA. What should be the ideal reference standard or gold standard? The control population should be okay. Any other? Any other? These are the choices: biopsy, CT scan, digital rectal examination, total prostatectomy, transrectal. Biopsy, histopathology, radiological examination. Radiological CT scan, you mean? You have to choose one of them. ABC, you can write A, B, C, D, E. Any one of them. Biopsy. IHC. Immunohistochemical. That is after biopsy. Yes. Biopsy. Actually, if the problem is that the gold standard, if you can do of course it is total prostatectomy, because the problem with biopsy is that you may not be hitting the same area where there is a cancer is lying. So ideal is total prostatectomy, but you cannot do total breast. Of course you cannot do. Then you resort to the biopsy. So in clinical practice you can use biopsy, but actually the gold standard is total prostatectomy. Just for your enjoyment. Now we actually go for the attribute of the test, which is the sensitivity, specificity, receiver operator characteristic curve. The real name is receiver operator characteristic curve. Likelihood ratios of positive, likelihood ratio of negative test, pre-test probability, post-test probability, and we will one by one we will discuss how to do these attributes. Sensitivity. What is sensitivity? It is the proportion of those people who really have the disease and who are correctly identified as such. Now, in simple language, first I will say in English and then in Urdu. That sensitivity is the ability of the test to pick up the disease out of the disease population. Ability of the test to pick up the disease out of the disease population. If you still couldn't get it, तो ये नहीं मैं कह रहा कि आपको अंग्रेजी नहीं आती, इसलिए कि जरा शायद लैंग्वेज चेंज करने से आपको और समझ आ जाए कि एक आप समझ लें कि 100 लोग बैठे हैं जिनको डिजीज है कोई, ठीक है, और आप एक नया टेस्ट इंट्रोड्यूस कराते हैं और वो 100 में से 80 को कह देता है कि इसमें वो डिजीज है, और आपको पहले से पता है कि वो डिजीज 100 के 100 लोगों में मौजूद है, तो 80 को वो कह देता है कि है, 20 को वो कहता है कि नहीं है, तो जो 80 उसने ढूंढे हैं वो ट्रू पॉजिटिव है, और जो 20 उसने कहा कि नेगेटिव है वो एक्चुअली फॉल्स नेगेटिव है। तो ये है सेंसिटिविटी, यानी सेंसिटिविटी को हम डिजीज पॉपुलेशन के रेफरेंस से करते हैं। इसका बड़ा सिंपल फार्मूला है, टोटल पॉजिटिव ओवर टोटल पॉजिटिव प्लस फॉल्स नेगेटिव। जो 100 थे वो सारे डिजीज थे, उनमें से 80 को उसने ट्रू पॉजिटिव कहा और 20 जो है ना वो फॉल्स नेगेटिव हुए। सो दिस इज द 2x2 टेबल that this is the test and this is the disease. And how we found out the disease? We found out the disease based on reference standard. The gold standard has to, because gold standard cannot tell a lie, so gold standard has to be true. So this is the sensitivity. Similarly, specificity is the proportion of those people who really do not have the disease, who are correctly identified as such. अब हम उल्टा करते हैं, हम 100 हेल्दी लोग ले लेते हैं, बिल्कुल हेल्दी नहीं कहना चाहिए, वो लोग जिनमें वो स्पेसिफिक डिजीज नहीं है जो हम डायग्नोज करनी है हमने। फॉर एग्जांपल we take 100 people and we are sure we have done the gold standard and we know that they do not have the disease, so now we carry out that test on 100 disease free people, and 80 out of these 80 people, our test says they do not have disease, but in 20 the test says the disease is present. So this is true negative, 80 is true negative, and 20 is false positive. So in specificity, true negative is divided by true negative plus false positive, because true negative plus false positive, they are the disease-free people. Now, question number 2 is, in which of the following situations specificity and sensitivity cannot be calculated by usual formula? Data of alpha fetoprotein with a cutoff value of 500 and liver biopsy. Data of FNA, breast and excisional biopsy. Data of PSA without any established cutoff value and prostatic biopsy. Now, which you have to select me A, B, C. In which situation you cannot calculate specificity and sensitivity? The answer has come. C. Dr. Taiba, C. Dr. Hina, C. Yes. Any other? Yes, you are very right. We cannot calculate diagnostic accuracy, specificity, sensitivity on in the situation of C. Data of PSA without any established. So this is the problem, that for diagnostic accuracy, the data has to be dichotomous. Yes, no. And if it is not dichotomous, you have to convert it into the dichotomous data. So an important requirement of specificity sensitivity is data has to be dichotomous, that is yes or no. You cannot in continuous data you cannot apply specificity and sensitivity, or data converted to dichotomous. For example, dividing patients on the basis of cutoff limits of TSH into hypo or hyper and euthyroid. So you this is a very, very important concept to be understand, that you cannot apply you cannot calculate specificity, sensitivity, etc. on a continuous data. Uh, yes, for FNA, because either tumor pregnancy is present or not present. For TB test, TB is present or not present. But what about the tests which do not have a very fixed cutoff value? So you have to then find out the cutoff value and divide it into yes or no type. Only then you can apply it. How to apply these statistical when definite cutoff values are not available? This is the answer. In such situation, when you do not have a cutoff value, you use receiver operating characteristic curve, ROC curve, receiver operating characteristic curve. This is a very good method of determining the cutoff values. And we borrowed, the medical field has borrowed this technique from Air Force. This is very interesting. In Second World War, the radars were newly invented, and they used this technique of receiver operating characteristic curve for finding out that the particular image seen on the radar, how much likely that it is an enemy aircraft or not. So this technique is now used in medical science also. Now, question number 3 is, a pathologist wants to use TSH only regime screening for screening of thyroid disorders. Which of the following attribute is most important? Yes, which of the following attribute is most important requirement of the TSH? Now, TSH is now very has become quite sensitive, and we want to use it for screening of thyroid disorders. TSH only, not any other test, not T3, T4. So which of the very important requirement for TSH you will like to have? High sensitivity, yes. C, high sensitivity. High sensitivity. This is very important. So whenever you want to do a screening test, you should use a test with high sensitivity. Uh, I give you a situation. For example, you are carrying out a sensitivity for TB, tuberculosis in a population. Screening means that you are doing the test in healthy population. They are there, and you go to the patient. Patient do not come to the hospital. Uh, the particular academic definition of screening test is the test which is done by going to the patient, because patient is otherwise normal. It does not it does not have any symptoms or any problem. So and if the test is negative, you do not bother anything more, and you simply say that that particular disease is not present. So if you want to use the test for this particular situation, the test has to be very good sensitive, because do not want uh, false negatives. You cannot afford false negatives if you are using the test uh, for screening. So sensitive test to rule out snout. This is the snout is the abbreviation or mnemonic which you can use. Sensitive test is able to pick up affected person, used to rule out diagnosis, used when there is a penalty in missing a case. Diagnosis of a dangerous but treatable condition, for example, tuberculosis. Blood screening for HIV, used at an early stage of diagnostic workup. A sensitive test is most useful when negative. So please remember, when you want to do screening, for example, HIV, HCV on blood donors, you have to use a very sensitive test with a high sensitivity. Specific test for rule out, and it is SPIN. SPIN is specific test for rule in. The previous was snout to rule out, and SPIN is to rule in. Rule in means now you want to carry out a definite treatment for the disease. So your screening tests have found out that the patient has got tuberculosis, for example. Now you want to be sure that the patient has got tuberculosis or HIV or cancer, and now you want to do the test which is very high specificity, which cannot give false result, and because you are now embarking on a definite treatment for the disease. So SPIN is for the specific test to rule in, and SNOUT for sensitive test to rule out. Please, if you can remember it. Question number 4. In the scenario of question 3, 2 firms have offered TSH assay kits with following specifications. We are just talking on clinical sensitivity, not analytical sensitivity. TSH, there are now recommendations that TSH only should be used, and you want to use a very high sensitivity test. So firm A has quoted a kit which has got 94% sensitivity and 45% specificity. Firm B has offered a kit with 90% sensitivity and 81% specificity. Which firm he should select for procurement of TSH kits for a cost-effective and safe screening of them? Let's see, what are your examples? A, B, B, B. Dr. Saida, B, Dr. Hina, A. Okay, so there is a mixed answer, and mixed answer always excite me. Dr. Nabila, A. Okay, you can, other people can also write your answer. Dr. Saida, A. Okay, let's see. Now, the problem is, yes, we say that high sensitivity is required for screening test, but we should also consider some specificity, because if let's assume that we select this firm A and we get high sensitivity, but there are false positive results because the specificity is very low. So what will the cost effectiveness will be reduced. So there will be many falsely included patients, and on the further testing they will be found actually negative. So the cost of the screening will be, or testing will be increased. So we should do some trade-off. 90% sensitivity is good enough, but specificity should also be reasonable. So best answer is form B. So don't ignore specificity, because otherwise your test will become, your lab or your system or your health system will become less cost effective. So you should go for good sensitivity, but also consider specificity. So cost consideration is very important. In screening tests, the positive test samples are tested by another test or imaging. If you choose a test with very high sensitivity but low specificity, the number of false positive tests will be high and cost will increase. So from feasibility point of view, a test with high sensitivity but reasonable sensitivity specificity is chosen. Now, this is a very important question, and question 5. Now we go to the question 5. This involves a lot of your brain work, a lot of critical thinking is involved. So if you have already gone somewhere else, please come back to the talk and give your answer after some thinking. A pathologist is working on determination of specificity and sensitivity of PSA at various cutoffs. Which of the following is the lowest cutoff? I give you in simple words. Pathologist ने 3 cutoffs निकालनी है, C1, C2, C3, whatever they are. C1 जो है ना वो बहुत कम है, फॉर एग्जांपल सिर्फ 2 नैनोग्राम है और उसकी सेंसिटिविटी 98% है. C2 है और C3 भी है. तो कौन सी आपके ख्याल में कट ऑफ सबसे कम है? इन तीनों में कौन सी कट ऑफ सबसे कम है जिसकी सेंसिटिविटी बहुत अच्छी है और स्पेसिफिसिटी बहुत कम है? ऐसी कौन सी कट ऑफ है जिसकी सेंसिटिविटी बहुत ज़्यादा है और स्पेसिफिसिटी A? Okay, Dr. Aisha, you have written A. Any other answer? If you have understood the concept of this specificity, you can answer this question. Dr. Salma, A. Dr. Noman, B. Dr. Sajad, 3. Okay, let's see if I can wait for 10 more seconds if somebody else want to participate in this quiz. There is another answer. Dr. Hina, A. Dr. Nabila, B. The question is, which sensitivity is the lowest in this situation? It is A, because when you decrease your cutoff very low, I give you an example of this PSA that for example, we say the sensitivity, the cutoff will be 2.5 nanogram. Anybody 2.5 and above will be labeled as CA prostate. So we will not miss any CA prostate, and our sensitivity will be very high, whereas specificity will be low because 2.5 is quite low, and many patients will be false positive. Similarly, if we increase it to 6, the sensitivity will decrease, but specificity will be increased. And if we increase it to 10, sensitivity will be very low, but if specificity will be high. Why? If we say that anybody above 10 nanogram is having a prostate cancer, then surely we will miss many patients whose PSA will not be very quite high, but since our cutoff is quite high, we will miss those. But when we say it is CA prostate, there is likelihood that the biopsy will also be positive. So if we decrease the cutoff, the sensitivity increases. Now, task 5. A lab test for Mycobacterium tuberculosis is carried out at AFIP round. You know AFIP, Armed Forces Institute of Pathology. This is probably the biggest labs, one of the biggest labs in Pakistan, very big. lab, and if you're a pathologist, you must visit this lab, at least see, you can see all the department working under one roof. And there is a lab in UK with almost equal accuracy. They are doing on their own population Mycobacterium tuberculosis test. So the question is, uh, the positive predictive value at A5P is 61%, positive predictive value at UK lab is 36%. Now the question is, why the difference? Why is the difference? We suppose that here population is vaccinated. Okay, UK has less cases of tuberculosis. Prevalence, difference in prevalence, strain. Not Dr. Saida, we suppose that the strain is the same. Strain is same. Difference in prevalence. Okay, let's see. Any other answer? This is again a very important concept. We have more patients. Dr. Samairam, good. We have more patients. Yes, the predictive values depend on prevalence of the disease. Now we are going on the second part, which are the predictive values. But right from the beginning, you must understand that predictive values depend on the prevalence. This is very, very important. A pathologist working on determination of predictive values of various tests. Which of the following tests has the highest positive predictive value, assuming these tests are being done for the same disease in the same community? अब हमने एक ही कम्युनिटी में ये टेस्ट हो रहे हैं, सेम टेस्ट है और सेम कम्युनिटी में है, ठीक है, सेम कम्युनिटी में सेम डिजीज के लिए हो रहा है. टेस्ट डिफरेंट है लेकिन डिजीज और कम्युनिटी सेम है. टेस्ट ए की जो सेंसिटिविटी है वो 98% है और स्पेसिफिसिटी 96% है, और टेस्ट बी की सेंसिटिविटी 95%, 54% एंड इस तरह सी की है. तो मेरे ख्याल आंसर आने शुरू हो गए. वी हैव मोर. नो, अभी नहीं आया आंसर कोई. इसका आंसर दें ए. डॉक्टर फायजा, डॉक्टर सलमा, ए. ओके ओके, लेट्स सी. There is another two more answers. Dr. Taiba A, Dr. Saimairam A. Okay, let's see what is the answer. Yes, you were very right, A, because when the sensitivity is high and specificity is also quite high, the positive predictive value will be high. How? We can see now. Now we come to the predictive values. Predictive values are two: positive predictive value or negative predictive value. Positive predictive value is the proportion of the people who test positive out of the positive. Total positive plus false positive who truly have the disease. For example, right from the beginning, मैं एक एग्जांपल आपको देता हूँ और उर्दू में देता हूँ. अभी पिछले दिनों कोरोना चल रहा था, ठीक है. लेट्स से कि बहुत हाई वेव थी और शुरू का पहली दूसरी वेव थी, पिछले साल 20 की बात है. तो जिस बंदे को फीवर होता था, फीवर और जुकाम हुआ, उसको गला खराब हुआ, खांसी और फीवर हुआ, तो एकदम सब कहते थे ये कोरोना है, और वो निकलता भी था कोरोना, ठीक है. जबकि उससे पहले, कोविड से पहले, किसी को फीवर या होता था, कफ होती थी, तो आप कहते थे कोई बात नहीं, ये सीजनल है, ये आम फ्लू है. कभी सीरियस कोरोना वायरस सब भी थे, किसी का उस वक्त ख्याल नहीं जाता था. तो अगर हम ये क्लिनिकल टेस्ट है, फीवर भी एक क्लिनिकल टेस्ट है, कफ भी एक क्लिनिकल टेस्ट है, तो जब प्रिविलेंस उस डिजीज, और हम इसको फॉर एग्जांपल हम पॉजिटिव प्रेडिक्टिव वैल्यू निकाल रहे हैं फीवर की फॉर कोरोना, तो जब कोरोना बहुत ज़्यादा फैला हुआ था तो फीवर की पॉजिटिव प्रेडिक्टिव वैल्यू बहुत हाई थी, ठीक है, क्योंकि डिजीज प्रेवलेंट थी. जब ये कोरोना नहीं था, या कोरोना जब अल्लाह करे इंशाल्लाह ख़त्म हो जाएगा, फिर फीवर भी होगा तो कोई ऐसा परेशानी वाली बात नहीं होगी, तो क्योंकि उसकी प्रेवलेंस कम हो जाएगी तो पॉजिटिव प्रेडिक्टिव वैल्यू भी कम हो जाएगी. एक और एग्जांपल मैं आपको देता हूँ. अभी रिसेंटली जो 2 टेस्ट सबसे ज़्यादा यूज हुए, बहुत ज़्यादा उनकी यूटिलिटी हुई, एक पीसीआर की और एक एचआरसीटी की. पीसीआर की मैं अभी हम डिस्कस भी करेंगे. पीसीआर की सेंसिटिविटी कम थी फॉर पीसीआर फॉर कोरोना, तकरीबन कोई 60% थी। ये आइडियल नहीं था, ये पक्की बात है, ये आइडियल नहीं था। लेकिन अगर किसी में पॉजिटिव आ जाता था तो कहते थे कोरोना ही है। यानी पीसीआर की स्पेसिफिसिटी बहुत अच्छी थी, लेकिन पीसीआर की सेंसिटिविटी कम थी। लेकिन एचआरसीटी की, लोग कहते थे एचआर, बहुत सारे पेशेंट थे जिनको पीसीआर तो नेगेटिव था लेकिन एचआरसीटी पॉजिटिव था। अब एचआरसीटी बिल्कुल गोल्ड स्टैंडर्ड नहीं है पीसीआर के लिए, कोरोना के लिए, बिकॉज वो ये तो नहीं कहता कि इसमें ये पर्टिकुलर वायरस मौजूद है। गोल्ड स्टैंडर्ड तो इसमें वायरस कल्चर ही है। लेकिन जो खास पेस्टीज हैं, ग्राउंड ग्लास पेस्टी, अगर कोरोना प्रेविलेंट हो और किसी के एचआरसीटी में ग्राउंड ग्लास पेस्टीज आ जाएं तो काफ़ी चांसेस हैं कि उसको कोविड ही होगा। तो इसलिए पॉजिटिव प्रेडिक्टिव वैल्यू प्रेवलेंस पे बहुत ज़्यादा डिपेंड करती है। अब कुछ साल गुजर ही जाएंगे इंशाल्लाह, जब कोविड ख़त्म हो जाएगा तो जब एचआरसीटी किसी का कराएगा और जीजीओज नज़र आएंगी ग्राउंड ग्लास पेस्टीज, तो किसी का ख्याल कोविड पे नहीं जाएगा, बिकॉज उस वक्त वो डिजीज प्रेवलेंस नहीं होगी। सो ये जो है पैरामीटर, ये ख़ास तौर पे प्रेवलेंस पे डिपेंड करता है। इसी तरह बिल्कुल नेगेटिव प्रेडिक्टिव वैल्यू है। नेगेटिव प्रेडिक्टिव वैल्यू जो है वो ये है कि द प्रोपोर्शन ऑफ द डिजीज पीपल आउट ऑफ द नेगेटिव पॉपुलेशन, यानी ट्रू नेगेटिव आउट ऑफ द ट्रू नेगेटिव प्लस फॉल्स नेगेटिव, और ये भी प्रेवलेंस पे डिपेंड करता है। So predictive values are dependent on the prevalence of the disease. Our population is often quite different from study population. They are influenced by the prevalence of disease in the population, that is. So if अब इसमें लेसन क्या, लेसन ये है कि जब आप कोई भी आर्टिकल पढ़ रहे हो और उसमें देखें कि किसी टेस्ट का प्रेडिक्टिव वैल्यू कम है पॉजिटिव, तो आप ये ना समझेंगे वो टेस्ट खराब है। हो सकता है उसकी जो प्रेवलेंस हो उस डिजीज की उस पॉपुलेशन में कम हो। तो ये हमेशा ज़हन में रखिएगा। अब ये एक्चुअल एग्जांपल है, बस मैं 2-3 मिनट में ख़त्म कर रहा हूँ जी, इंशाल्लाह 2-3 मिनट। ये एक प्रेवलेंस है, एक पॉपुलेशन में 2% और एक में 98%, दोनों में हमने 1000 टेस्ट किए। तो सेंसिटिविटी स्पेसिफिसिटी उस टेस्ट की बिल्कुल एक जैसी रिपोर्टेड है, बिल्कुल एक जैसी है। तो कैलकुलेशन के बाद देखा कि नेगेटिव पॉजिटिव प्रेडिक्टिव वैल्यू 2% पॉपुलेशन में सिर्फ 17.6% थी, जबकि पीपीवी दूसरी पॉपुलेशन जिसमें 98% पॉजिटिव था वो 99.8 थी। ये मैं स्लाइडें आपको शेयर कर दूंगा, यू कैन डू दिस कैलकुलेशन yourself and then you can find out.
We will also share the this whole your
The
lecture
recording also. So here I will stop because of time constraint. This is
अगला
Sunday.
छठा क्वेश्चन कर दें, अगला छठा क्वेश्चन कर दें।
अच्छा ठीक है। अब ये रिसीवर ऑपरेटिव क्रेस्टिक कर्व है, इसके लिए मैं छोटा सा एक एनेक्डोट बताऊंगे। ये बहुत कम लोग सुना तो होगा लोगों ने, लेकिन बनाने में थोड़ा सा इश्यू होता है। एक दो बार मुझे लाहौर से कॉल आई थी कि किसी को नहीं आ रहा बनाना तो कैसे बनाएंगे। तो ये बहुत आसान है, ये SPSS पे आप इसको कंस्ट्रक्ट कर सकते हैं। और इसके दो बहुत टास्क हैं इम्पॉर्टेंट। जो मैंने कहा था ना कि कट ऑफ नहीं मिलती आपको, अगर किसी आपको टेस्ट की कट ऑफ डिटरमिन करनी है तो यू कैन यूज ROC। ROC आपको कट ऑफ भी देता है और वैलिडेशन ऑफ टेस्ट भी देता है। ये डॉक्टर नुज़रत ने भी इस पे थोड़ा सा बताया था आपको कि ये एरिया अंडर कर्व जितना ज़्यादा होगा उतनी ज़्यादा उस टेस्ट की वैलिडिटी होगी। जनरली 80 से ऊपर जो या 0.8 से ऊपर जो एरिया अंडर कर्व है, ये टेस्ट इज एक्सीलेंट। एंड 50% जो है ना वो 50 से ऊपर हो तो बिल्कुल पास होता है टेस्ट। तो इंशाल्लाह फिर हम इसको करेंगे और कभी फिर मौका मिला तो आपको मैं एक्चुअली SPSS के ऊपर ROC कर्व बनाना भी दिखा दूंगा और उसकी वीडियोस भी भेज दूंगा। और इसके अलावा फिर बाकी प्रेडिक्टिव वैल्यूज भी हम बाद में कर लेंगे। तो आज के लिए इतना ही है। थैंक यू वेरी मच वंस अगेन टू ऑल ऑफ यू फॉर गिविंग मी दिस अपॉर्चुनिटी एंड बीइंग विद मी। थैंक यू।
Thank you, Professor Amar. You have given such a important lecture and very complete lecture. There is no need of any comments from my side of the panelist. यकीनन these values are not only important. एक चीज ऐड करूंगा कि ये सिर्फ इम्पोर्टेंट क्लिनिकल लेबोरेटरी के लिए नहीं है. योर लेक्चर इज वेरी इंपॉर्टेंट इन मेकिंग द रिसर्च एंड एनी ऑफ द, जब भी हम कोई प्रोजेक्ट करते हैं तो उसके अंदर ये सारी चीज़ें जो सेंसिटिविटी, स्पेसिफिसिटी, एक्यूरेसी, नेगेटिव प्रिडिक्टिव वैल्यू, पॉजिटिव प्रिडिक्टिव वैल्यू बहुत इंपॉर्टेंट होते हैं. तो मैं इतना कहूँगा, इफ़ एनीबॉडी है आस्क एंड वेल डन. और आपकी जो इंटरैक्टिव लेक्चर था, और आपके क्वेश्चन आंसर थे वो बहुत ही थे. और बल्कि साथ साथ मैं किसी और ग्रुप में भी शेयर कर रहा था, उनसे भी अपडेट साथ साथ लेता रहा था फोटोग्राफ में. अच्छा, किसी ने सवाल पूछना हो तो मुझसे हाथ खड़ा करें, और अगर नहीं है तो फिर आज के लेक्चर्स का हम इख्तिताम करते हैं. एनी क्वेश्चन फ्रॉम क्लिनिकल साइड? कैसर सजाद और काजी साहब और मैडम, एनी क्वेश्चंस?
अस्सलाम वालेकुम सर, मेरा क्वेश्चन है
जी
डॉक्टर
साइमा इरम, वेलकम. जी पूछें.
सर, मैं बेसिकली हीमेटोलॉजी स्पेशलिटी से बिलोंग करती
जी
हूँ.
आपका हेमाटोलॉजी से जी.
सर, बहुत बेसिक सवाल है, मैं इन सारी चीज़ों को समझने की कोशिश कर रही हूँ. मुझे ये पूछना है कि क्वालिटी कंट्रोल और क्वालिटी एश्योरेंस क्या दो डिफरेंट चीज़ें हैं
ये
या
अगला लेक्चर हमारा आ रहा है, इसके ऊपर क्वालिटी कंट्रोल, क्वालिटी
नहीं
एश्योरेंस
सर,
के
मैं
ऊपर.
बता देता हूँ, एक
जी
मिनट.
सर,
वो
जी सर.
डॉक्टर साहब मैंने पूछा है तो ये हमारा फर्ज बनता है कि हम साथ ही बता दें. डॉक्टर साइमा, मैं सॉरी आपको बेटा ही कहूँगा क्योंकि आप जाहिर है छोटी होंगी बहुत. मेरी आदत है बेटा कहने की. तो बेटा, ये जो है ना क्वालिटी कंट्रोल होता है सिर्फ जो प्रोडक्ट को चेक करना, यानी जब हम जो नॉन सैंपल होते हैं
बन
हमारे,
जाता है जब. हाँ.
बन जाता है,
हाँ.
प्रोडक्ट तैयार होता है, उस वक्त जो चेक करते हैं ना, जो हम सारा दिन क्वालिटी कंट्रोल लगाते हैं. क्वालिटी एश्योरेंस ये होता है कि वो सारे प्रोसेस लेबोरेटरी के अंदर, रीजन स्टोरेज है, टेम्परेचर है लेबोरेटरी का, मेंटेनेंस ऑफ द इंस्ट्रूमेंट्स वगैरह, उनको सबको ठीक रखना ताकि हमारा क्वालिटी कंट्रोल फेल ना हो. क्योंकि क्वालिटी कंट्रोल फेल होता है तो हमें वो टेस्ट रोकने पड़ते हैं और वो दोबारा करने पड़ते हैं, तो वो कॉस्ट बहुत बढ़ जाती है. तो इसलिए क्वालिटी एश्योरेंस ये कहते हैं कि टेस्ट फेल, कंट्रोल फेल ही ना हो आपका, तो
जी,
आप पहले
वेरी
से
नाइस. हमारा
प्रोसेस को
प्रोडक्ट बिके सही, बल्कि वी विल
बिके सही.
इंशाल्लाह. वेल,
बिल्कुल.
थैंक यू
हाँ.
डॉक्टर आमिर.
थैंक यू सर.
अगला लेक्चर ही इरम, बेटा आपका अगला लेक्चर ही पूरा हमारा इसी पे है. जो बड़ी सिंपल सी मिसाल इन्होंने दी है सर ने, कि एक आप प्रोडक्ट बनाते हैं और उसके बनाने में क्या हमारे एहतियात करनी चाहिए ताकि बने सही. और अब जब हम बनाने के बाद किसी प्रोडक्ट को बेचते हैं तो उसके अंदर, हमारे बेचने के अंदर भी, यानी अगला यूटिलाइजेशन में भी हमारा क्वालिटी कंट्रोल होना, दैट इज कॉल्ड द क्वालिटी एश्योरेंस. एनीबॉडी एल्स? जी डॉक्टर साइमा इरम, एनीबॉडी एल्स? नुमान साहब, सजाद हैदर, मोहसिन. ओके, इफ यू डू नॉट हैव एनी क्वेश्चन, काजी साहब आपको क्लिनिकल साइड से कोई क्वेश्चन है? काजी वासिक साहब, मैडम सलमा कुंदी.
जी, क्वेश्चन तो नहीं है, मैं सिर्फ जरा आमिर
जी,
साहब,
आज का
इजाज साहब को
इख्तिताम भी कर दें मैडम, आज के लेक्चर का इख्तिताम भी कर दें.
अच्छा जी, ओके, इख्तिताम भी कर देते हैं. सबसे पहले तो ब्रिगेडियर आमिर इजाज साहब का बहुत शुक्रिया. मेरे दिमाग के दरीचे उन्होंने बहुत खोल दिए हैं, क्योंकि हम पेपर्स पढ़ते थे, टू टेल यू द ट्रूथ बहुत बातों की समझ नहीं आती थी. चैट्स में भी लिखा हुआ है, मुलाजिम, प्रोफेसर मुलाजिम साहब एंड काजी साहब, लोग पूछ रहे हैं कि हमें ये लेक्चर्स कहाँ से मिलेंगे. तो आई टेक दिस अपॉर्चुनिटी ऑफ टेलिंग देम कि ये यूट्यूब मुलाजिम साहब का भी है और
जी,
हमारा
मैं इनको
पीएमए
भेज
का
दूंगा
भी है.
मैडम, इनको भेज दूंगा जी, भेज
अच्छा,
दूंगा, मैं
आप
भेज.
अपना भी भेज दीजिए, पीएमए का भी. काजी साहब प्लीज आप लिंक
जी
भेज
दोनों तरफ
दीजिएगा
से भेज देंगे, दोनों लिंक भेज
ताकि
देंगे.
दोनों तरफ से ये डाउनलोड
जी,
करते
दोनों
रहें.
तरफ से डाउनलोड हो सके.
ये हमारे जो 6 सीरीज ऑफ लेक्चर्स है, ये तो बहुत ही जबरदस्त है. आज चौथा हो गया, जो कि ब्रिगेडियर साहब ने बहुत अच्छी तरह हमें समझा दिया था. और इसी सीरीज में प्रोफेसर नुज़रत मुशाहिद साहिबा थी, आज भी मौजूद है. नुज़रत साहिबा का भी मैं शुक्रिया अदा करती हूँ, उन्होंने भी हमें बहुत अच्छी तरह समझाया था. डॉक्टर रफीक खनानी का भी इसमें बहुत बड़ा कंट्रीब्यूशन था. थैंक्स टू ऑल थ्री. थैंक यू Dr. Mulazim Saab, you are the man behind the gun for organizing these webinars. Hats off to you and hats off to काजी वासिक साहब, क्योंकि वो हमारा सब कुछ डील कर रहे होते हैं वेबिनार की एंड में. हमारे पीएमए के ट्रेजरर भी हैं और समाओ के एक्टिंग प्रेसिडेंट भी हैं. आई विश यू ऑल अ वेरी हैप्पी संडे. अल्लाह आप सबको ओमिक्रॉन से महफूज रखे और हर बलाओं से महफूज रखे. थैंक यू सो मच जी.
इलाही
अल्लाह
आमीन,
हाफिज.
इलाही आमीन मैडम, इलाही आमीन मैडम. इंशाल्लाह ये जो मैं अक्सर कहा करता हूँ मैडम, जो ओमिक्रॉन, आफ्टर द ओमिक्रॉन, ये जैसे ही 2-3 महीने के बाद इसने डाउन हो जाना है, तो कोरोना विल बिकम ए फ्लू लाइक कंडीशन. दिस इज द ब्लेसिंग इन डिस्गाइज. दीज आर नॉट माय वर्ड्स, बट दीज आर माय कैलकुलेशन एज ए साइंटिस्ट. तो इंशाल्लाह ये जो हमारा कोरोना का ये लास्ट वेरिएंट है, एंड आफ्टर दैट द कोरोना विल बिकम जस्ट लाइक ए फ्लू लाइक कंडीशन. बट वी मस्ट बी केयरफुल, वी मस्ट बी अडॉप्ट द, कहते हैं ना, कोविड एटीट्यूड. कोविड एटीट्यूड बिहेवियर ही होता है, कोविड बिहेवियर ही होता है. वी मस्ट अडॉप्ट द SOPs. थैंक यू सो मच, thank you so much everyone, thank you so much Brigadier Amir Ijaz, thank you so much all the participants. Inshallah, as Madam Salma Kundi has advised us, we will inshallah upload these lectures. One lecture is present on the PAP side, and other lecture will be present on the PMA side.
PMA.
Thank you so much. Thank you. Dr. Rafiq Hanani, you are present. Can you give some comments? Just I am looking you, sir. Last comments. Can you give, Professor?
Yes, it has been an excellent presentation today as well as the last one.
Really.
I enjoyed it, and I think that our junior colleagues must have learned a lot about it. So this series really deserves the applause for you as well.
Inshallah.
Because you are behind the gun. So, and I hope that this thing will continue.
इंशाल्लाह. इंशाल्लाह ये इंशाल्लाह सर, हम नहीं भी होंगे तो ये कंटिन्यू रहेगा इंशाल्लाह सर. इंशाल्लाह.
और खासतौर पर जो आपका ये विजन है कि ये हमारी वेबसाइट पर अवेलेबल होगा,
जी सर,
so that people can get benefited.
Definitely these all lecture will be available, and inshallah these series will be continued. These educational academic series will be continued forever, inshallah. Thank you so much, sir.
PMA really deserves for it a big applause.
So much, sir. Thank you so much. Allah Hafiz, Allah Hafiz, Allah Hafiz, Allah Hafiz, Allah Hafiz.
Allah Hafiz.